Working for the Bart's fast. Okay, so before that, I'm not sure whether Tom would like to introduce anything at all. Tom, would like to say anything at all, or just we can continue?
No, sir. We are on live now.
Okay.
Can start.
Okay, right. So yes, I mean this is presentation is going to be done by my FY1. But before that, we already know about Planetary Health Academia. PHA, Planetary Health Academia, is based in Bangladesh now, but I think this is mainly formed from the doctors, Bangladeshi origin doctors from America, United Kingdom, Australia, and also New Zealand, but in collaboration with the Bangladeshi professors and Bangladeshi doctors and students as well. So we've been working for last almost 2 years, and this PHS, this is routinely happening every weekly basis, and every weekend we have got different types of seminars or webinar with different topics with consultants from different parts of the world. It's not only teaching, it's just discussing about how to manage patients, not only from the Western countries' point of view, it's also we're learning from Bangladesh perspective as well. Now, let me introduce to our my presenter, Dr. Shannon Bernard Healy. He's, as I said, he's my FY1, but he has graduated from Cambridge University, and at the same time, he has done a BSc degree in neuroscience from Cambridge as well. So, at the same, and he is very keen to go further. I'm not sure whether he has decided to stay in surgery or go to medicine, but he'll be a very good, definitely very good doctor in future. And he will present in a few minutes. And let me introduce you to our panelists. We have got Professor Dr. Shahadat Hussain Sheikh, is a professor of colorectal surgery, BSMMU, Dhaka, Bangladesh. I'm sure everybody knows him, and he's a very good colorectal surgeon. Next, let me introduce you to Professor Samia Mubin. She's a professor of surgery, BSMMU, Dhaka, Bangladesh, professor of general surgery as well as breast surgery as well. And last but not least, we've got Professor Dr. Kondokar A.K. Azad, and he is the professor of surgery, just retired recently, and from Chittagong Medical College, Bangladesh. And I'm really grateful to all of you for joining to this webinar. So, Shannon, I'll not delay you anymore. You can start your presentation, and the floor is yours.
Thank you, Mr. Ullah, for that introduction. Yeah, as you've heard, my name is Shannon. I'm a junior doctor working with Mr. Ullah in Whipps Cross in Northeast London. And thank you to everybody in the audience and the panelists for convening this. I understand that you're all joining, many of you are joining at a very late in the evening. So thank you for coming and thank you for being here. So I'm going to do a short presentation on an interesting case that we had a couple of weeks ago. And I'm going to highlight the sort of interesting features, but we're also going to use it to highlight the principles of how to present a case effectively to your fellow colleagues and professionals. So the first thing I think to say about presenting these cases is that you need to prepare for your audience. And with that in mind, I'm aware that we have a lot of expertise in the audience online today, and I am by no means the most, anywhere near the most experienced surgical doctor. However, I do have experience presenting my research internationally, and I hope that you will learn something either surgically or in terms of how to go about presenting these cases. And please do feel free to comment as we go along. The other principles I'll be hoping to illustrate are that you need to do clear introductions, not just for the presenter, but also the context in which you're working. So, which I will do for you in a moment. The actual case needs to have a clear case history, and I would recommend not doing anything too unstandard. So we all are trained in the traditional medical method, and doing things in the order in which we're expecting keeps your audience on the same page. You don't want to jump around with the order, so that they know where you're at. I would recommend always putting in the radiology, even if you don't think it's that interesting or relevant. And if you can, put your test results in as a piece of media, because otherwise you will get the situation where you have many slides which just have written text on them. So if you have blood tests, put a picture of them rather than typing them out to make it more interesting for the audience to look at. Having said that, keep the slides simple. Don't use too many, about 1 per minute of your presentation. And then close your session with questions, and always allow plenty of time for people to ask questions. Don't march on. And then I would recommend giving your audience the learning points at the end, rather than doing it, which is commonly done. People summarize and then have questions. And then if you get a question that you can't answer, or you don't answer very well, the audience goes away remembering that you didn't answer the question very well, instead of remembering your key points that you have taught them. So I would recommend switching around the order there. Okay, so hopefully I'll be able to illustrate some of these points for you. So I've already introduced myself. This is the hospital where Mr. Uller and I work. It is an old, very large district general hospital, so non-specialist hospital in northeast London. It serves a deprived population, quite a diverse population. It's part of a larger NHS organisation called Barts Health, with some very specialist leading cancer, cardiovascular and neurological centres. And the consultant body is 11 general surgeons. So this is the context in which we're working. Okay. So our case is of a 45-year-old man who came in with abdominal pain. In terms of characterizing this pain, it was epigastric. It did not radiate anywhere. It came on 1 day ago, and it came on quite relatively quickly and has been progressively worsened since. It's relatively severe, and it's worse when he moves around. He didn't have any vomiting pre-admission, but the nurses reported that he vomited in the emergency department, but there was no hematemesis. His bowels had opened that day normally for him, not loose, not hard, no blood. He was passing urine normally. And otherwise, in the last few weeks and months, he's been well. He's had no coughs, colds, no other illnesses. So to summarize, we have a 45-year-old man who's normally fit and well with abdominal pain, severe epigastric pain. He had a background of thyroid cancer, for which he had a partial and then completion thyroidectomy a year before. Since this, he's taken calcium supplementation and levothyroxine. And his social history, he lives with his wife. He had a moderate alcohol intake according to the initial emergency department clerking, and he didn't smoke. So this is the history as presented by the emergency department clerking. And this is what they wrote in the electronic notes when they examined him. So they thought that he was in a lot of pain. He was cardiovascularly stable, normal breathing, and a very tender epigastrium. And in terms of his observations, I know it may not be very clear there for you, but just to highlight, he's stable. However, he has a very high systolic blood pressure of over 200. And this was their impression. So they thought the epigastric pain may be consistent with pancreatitis, or we know that other structures in that area could be gastritis, could be a stomach ulcer, or we could have referred pain across from the right upper quadrant as cholecystitis. And I think so far, this is a very reasonable differential diagnosis to start with for a generalist and non-surgeon. In terms of our initial investigations, analysis of the urine showed a little bit of white cells and protein in the urine, and a little bit of blood as well, but no nitrites. And the initial blood tests, I hope you're able to see them, not that they're written too small. On the left-hand side, we have the hematology. So it's fairly unremarkable. The white cells are slightly elevated. And on the right side, we have the other biochemical blood tests. So again, not hugely deranged. However, significantly, the calcium is very elevated, 3.6. And in someone with no known renal disease, we have a raised creatinine. So he's got an acute kidney injury as well, but without any derangement, significant derangement of the electrolytes. Just to show you how they progressed, because he was admitted on day 1 of the pain, but the surgical team didn't see him until later on. So we had some access to repeat blood tests by the time we saw him. And his hemoglobin has dropped from 143 to 119. Otherwise, the investigations are broadly similar. He remains hypercalcemic and remains in acute kidney injury. So before we saw him, our colleagues in emergency department luckily ordered some cross-sectional imaging for him, so a CT abdomen. And these are some of the images from that CT. Unfortunately, I'm not able to show you the actual CT scan live and scroll through all the slices with you. But these are some of the key images that were picked out by the radiologist who reported it. So this is a cut, transverse section through the upper abdomen. If you just familiarize yourself with the structures, we've got both the kidneys, the large vessels, and then the bottom of the liver here. And what we can see on this contrast enhanced scan is that we've got this large hyperdense mass in the upper abdomen under the liver. And the radiologist has reported that there is this blush of contrast from the vessel, from the artery, in the anterior superior aspect here. And just showing it in a different phase for you, it may be slightly clearer on your screens. I know that on my screen, this is not so clear, the differentiation in density between the abnormal finding and the liver, but this is much clearer on this right-hand side. We've got the normal liver edge down here, and then this more dense area here. But it's harder to see because this is not the right phase to see the contrast leak. So we can't see the contrast leak from the blood vessel. Okay. So at this point, this is how it was reported. And hopefully this makes sense to you from what I've explained, which is that there's a large hyperdense mass in the upper abdomen with some contrast leaking from the gastroduodenal artery. And they've advised surgical review and interventional radiology opinion and further triple phase CT angiogram imaging. And if you can see, the other thing which is important to note is that this happened overnight, and the radiologist raised this with the emergency general surgical consultant on call because they were very worried about this. So that's just to show you again the blush of contrast. This is the repeat CT, and I'm sure many of you may be able to get more but the findings are largely consistent with the previous scan, which is that we've got this hyperdense mass and obvious leakage of contrast, but of contrast in suggesting a catastrophic active bleeding. So at this point, to summarize, we have this 45-year-old man, normally fit and well. He's had a sudden onset pain, which is obviously quite suspicious for a vascular cause of anything, anywhere in the body. That's what we like to think of. If it's a sudden onset of pain, they can name the split second when it came on, and it's severe within the first few minutes. It's highly suspicious for vascular etiology. And he's dropped his hemoglobin. He remains hemodynamically stable. We've got this large bleed with retroperitoneal blood as well, but no active bleeding. And alongside this, he's got high calcium and very hypertensive. Yeah, so that's our situation. So the initial surgical plan, I'm sure many of you will already be formulating this in your minds, but to summarize, was that we would admit to surgeons, very sensible. We don't want to leave this man in A&E. Our emergency so we're going to admit him to surgical bed. We're going to try and dilute that calcium down because it's 3.6. That's exceptionally high, at risk of toxicity. He's in 8 out of 10 pain, so we're going to give him morphine pain relief. Keep him nil by mouth in case he needs a procedure. Discuss with our interventional radiology. So at Whipps Cross, we don't have interventional radiology overnight. This is something that in the UK, we only have at very specialist tertiary centres, major trauma centres. And so that was something that we would have to wait until the morning for. All of our patients, almost all of our patients get prophylactic low molecular weight heparin to prevent hospital-acquired blood clots and pulmonary emboli, but we're going to hold the enoxaparin due to the active bleed. Monitor urine output to ensure that he's not got a worsening AKI. Give a high-dose PPI in case this bleed is somehow related to an ulcer, duodenal ulcer. Repeat the HB to ensure that we're not dropping, that there's no further bleeding and we're not becoming anemic. Keep a very close eye on him with hourly obs. And stop giving him all of the calcium that he has been having in the community. So I think that was a very reasonable plan by the initial surgical team. I would say that, but because this was our plan. But I'm not sure if anyone can think of any other things that we've missed out. But this was just in the acute phase. So then we reviewed him later on in the day and discussed him with the IR consultant. And our interventional radiology consultants in the UK are generally very generalist, so they do a huge variety of procedures. So we didn't have a specific vascular specialist, and they felt that because there was atherosclerosis and calcification in the vessels in the celiac trunk, it would be quite high risk to do this embolization of this vessel as an emergency. And so therefore we should watch and wait while he remains stable. So that's our sort of interim plan to actually, in terms of definitive management. But whilst we were watching and waiting to ensure that he wasn't getting any worse, we took some extra background history on our first general surgery ward round, and we reviewed the images ourselves. And the more background is that he had a 2-stage thyroidectomy, like I said, for non-metastatic thyroid cancer. He was actually being investigated by his general practitioner, his primary care physician, for high blood pressure, and his ultrasound of his kidneys were normal, and he hadn't been started on any medications for that yet. He'd also had an adenoma in his colon, found on colonoscopy last year, and that was resected. And there were no other adenomas. It was just a single polyp. In terms of his social history, we always like to know about their occupation. This rarely tells us the diagnosis, although sometimes can. However, I like to know it because we have, sometimes up to 40 or 50 patients on per day on our surgical take, and it helps us remember who is who. And it also helps you remember when you're telling the patient about their diagnosis. It helps you tailor your explanations to the patient. I once tried to explain a diagnosis of MS to a professor of neurology in Cambridge, which was obviously a very fraught process because I did not know that he was one of the specialists, the world experts. So it's not. It's quite important to ask about that. He lived with his wife. He had a 2-year-old son. He had a plant-based diet. He drank very infrequently, about once a week, and not to excess. And he'd never smoked or vaped. And my consultant at this point made a joke that if a plant-based diet gives you intra-abdominal bleeding, he's never going to go vegan himself. He will stick to eating lots of meat. His family history: he had a maternal grandmother who died of thyroid cancer, and his father had cancer of the colon, although he did not die from this. So at this point, we were thinking we have a fit, healthy man in his 40s with a personal and family history of thyroid cancer, personal history of sigmoid adenomas, and he was presenting with a relatively unusual intra-abdominal retroperitoneal bleed. He was very, very hypertensive, very hypercalcemic. So we begin to think, could this be something rare or syndromic causing this constellation of symptoms? So to remind those of you who maybe have not done medical finals as recently, or not physicians, or these multiple endocrine neoplasia syndromes are relatively rare. And this is a summary from an image that I've taken from the internet. And if we think about how his presentation could fit into one of these columns, what we have is we have someone with very high calcium. So this could fit with a parathyroid lesion. We have someone with a retroperitoneal sort of possibly inflammatory, possibly neoplastic mass near the gastroduodenal artery. So it could be a pancreatic tumor. And we also have this history of uncontrolled, very high blood pressure in a young, relatively young man. So could this be some type of endocrine cause, like a pheochromocytoma? And he also has a history of thyroid cancer. So we have this situation where he's got some features from both multiple endocrine neoplasia 1 and 2A. But what I haven't told you is that actually, unfortunately, his thyroid cancer was not medullary subtype. It was a papillary thyroid cancer. And furthermore, these multiple endocrine neoplasia syndromes are very highly penetrant, meaning even though he's young, we would have expected him and his family to have some, and it's autosomal dominant, so we'd expect some family and personal history before the age of 45. So I think we realized that we got excited, but it's probably not one of these multiple endocrine neoplasias. And so we consulted our endocrine colleagues, and this is what they said. They said that the biliary thyroid cancer can actually be associated with syndromic colon adenomas, so familial adenosis polypi, and however, the presence of just one polyp maybe goes against that. They felt that the high calcium was probably due to being over replaced since his thyroid surgery, and that this may just be a standard essential hypertension which has not been treated. And actually, the likelihood is that one of the reasons for this catastrophic bleed is that he has been so hypertensive. Remember, his blood pressure was over 200 systolic. And they suggested some further blood tests and to get control of this blood pressure to avoid further rebleeding at the site. So all very sensible. In preparing this presentation, I do also want to tell you, though, that actually I learned that there's a fourth type of multiple endocrine neoplasia, which is much rarer and is I'd not heard of before, and it's quite consistent with the features of multiple endocrine neoplasia 1, but it additionally can have, in addition to parathyroid hyperplasia, pancreatic tumor, it can also have papillary thyroid cancer. So I do wonder whether that may have been a diagnosis that we should have considered, but it's sort of exceptionally rare. It's just a few case reports. Anyway, that's a side point. So we took him to Vascular MDT because, you know, we had this answer, which was that the non-vascular specialist interventional radiologist was not willing to intervene. So we said, okay, well, would the vascular specialist be willing to intervene to stop a rebleed? And actually they said yes. They looked at the radiology and they thought that there is a pseudoaneurysm, a small pseudoaneurysm in the gastroduodenal artery, which is responsible, probably in combination with the very high blood pressure. And that actually this must be treated. There's a high risk of rebleeding. You know, he's going to live for another 40 years. That's a high risk of rebleeding at some point. So he needs repeat imaging and embolization. So that's a more satisfying outcome for us and for the patient. And this is subsequently taken place. Just to broaden out the scope and just to give you a little bit of background on these pseudoaneurysms. Just a reminder, I'm sure I don't need to tell any of you, the difference between a true and pseudoaneurysm is about the number of layers involved, the type of defect in the actual vessel wall. So visceral artery pseudoaneurysms have a baseline prevalence of probably about 0.01% from the literature, but most of these are asymptomatic, and the most common, more than half, are in the splenic vessels. The gastroduodenal artery is very rarely involved. It's about 1% of the time. And in terms of etiology, it can broadly be thought of as either local inflammatory, and this is the most common situation. So half of the time they're due to pancreatitis, and a further 20% of the time they're due to a local inflammation due to a duodenal ulcer. So that's most of the time. You've got local inflammation causing some erosion and defect in the vascular wall. The second most common cause is iatrogenic, due to either interventional radiology, or sometimes the vessels can be, again, very mildly disrupted during a cholecystectomy, which then develop into a pseudoaneurysm later. And finally, more rarely, which interests me because I want to be a physician, we have the rarer causes in terms of intrinsic vascular issue, so either a genetic or an inflammatory condition of most commonly polyarteritis nodosa, because that's a medium vesicle vasculitis. And as a result, we sent tests for hepatitis B. It's hepatitis B is the most common single cause of polyarteritis nodosa, even though usually it is idiopathic. These bleeds from the gastroduodenal artery have very high mortality. So we're very pleased with the outcome in this case. And he was treated correctly by embolization with interventional radiology. So we have this patient that I'm very pleased to have shared with you. We found it very interesting to think about. There's lots of things to go on. Maybe unfortunately for the patient, unfortunately for us intellectually, there was no syndromic diagnosis which unified what was going on, but was this other rare interesting condition, which is the gastroduodenal artery pseudoaneurysm. So please, if anyone has any questions, feel free to ask now.
Thank you very much, Shannon. I'm just waiting for people to ask you questions, but this is quite an interesting case. And how often do you actually get this kind of cases? Very rare, as you mentioned, but still quite a lot of learning points from this particular case. I'll ask some of our students or juniors. Of course, anybody can participate. I can see almost 73 attendees here now. So it's a very good attendance, I must say. Thank you very much, everybody. Especially thank you all professors and panel of panelists. Definitely invited their students to come in as well. Now, anybody can comment about this presentation. At the same time, what would be your diagnostic pathway? What was your diagnostic pathway when we were actually going through this particular case? Did anybody actually thought about this particular pseudoaneurysm or gastroduodenal artery? Anybody can answer, please. It's not very common, I know that, but I think, was it in your differential diagnosis that it could be some sort of vascular problem causing this kind of big mass in the epigastrium, as well as there's a vascular leakage? When you put the contrast in, you've seen some leakage from arterial phase. Of course, in venous phase, we didn't see that one. Anybody from FCPS course? Please feel free. We are not actually testing your knowledge. We just want to discuss. Anyone? Anybody interested? So what are the, I mean, if that kind of situation is happening, and you've seen, I mean, of course, in Bangladesh, we don't have all these kind of facilities to different types of cities with interventional radiologists all the time. Do we have that kind of facilities in PG hospital? Professor Shahadat Sen.
Yeah, Zakirullah, thank you very much. Yeah, facilities for CT is fine. And in vascular surgery, probably they are doing CT angiogram. But why the students are not asking any question about this case? Because this is very, very uncommon case, first of all, so far I understand. Can you hear me?
Yes, we can. We can.
Yeah,
of course.
Okay. Okay.
Yes.
And
I'm not asking about particularly this case, but what was your thought process when this particular description was going on? What are the differential diagnosis came to your mind? This is a very rare case. That's why I'm saying that we are not asking people to learn much from this particular question. But MEN 1, MEN 2 syndromes, we all know about that, and whether it's fitting with that some sort of bizarre or some sort of difficult syndromes or not. Whether anybody thought about that process, because when calcium was high blood pressure, did anybody think about MEN 1? We know about that, don't we? Okay, it's a very,
It's a very, very difficult to comment because probably in this situation, we could go for a CT scan and seeing a mass in the epigastrium, there is a lesion that is obvious. So probably simple differential diagnosis we could think about, but still one important thing was there. Initially, the hemoglobin level was so far, and after that, so someone should think about this. Some bleeding must be there.
Yeah.
Otherwise, they suddenly hemoglobin fall. But one query: what about the pulse and blood pressure in the follow-up? With this patient when the hemoglobin fall down.
Yeah.
So with the hemoglobin level low and the blood pressure, so that is the massive hemorrhage, right?
Shannon,
Yeah.
what do you think? Yeah, it was.
Yeah, it was for sure. It's the serial hemoglobins showed over 30 or 40 units of hemoglobin drop, and if you remember the scan, the mass was about the hyperdense mass, which on the initial CT obviously it's very difficult to tell that it's definitely blood. It could have been a tumor bleeding into a tumor, but we now know in retrospect was blood. It was 6 by 8 centimeters. It's a large amount of blood, and there was also retroperitoneal blood with paracolic blood in the paracolic gutter. Yes, exactly, and that was our thinking. Even though we were not anticipating maybe one of a more rare bleed, the differentials for a very severe, rapid onset, severe epigastric pain, epigastric fullness on examination, and definitely a vascular cause should be part of, at least a triple A should be part of the differentials, in addition to the pancreatitis, which, with a peripancreatic collection could also cause epigastric fullness. But then exactly like you said, Professor, we've got this hemoglobin drop, which is, we have to have suspicion for bleeding. And like you said, I think very reasonable not to think about any of the more, the smaller vessels in the celiac trunk, but to at least consider AAA, very, very important for all of us juniors. There is a question in the chat I've just seen, which is very pertinent, which is, if there was a leak from the gastroduodenal artery, where was it leaking into? Could it be a bleeding peptic ulcer? So yes, very good, because peptic ulcer is the second most common cause of gastroduodenal artery pseudoaneurysm and bleed. In this case, he acutely didn't have hematemesis, and however, if I was actually to do the case again, knowing what I know about ulcers being one of the most common causes, I would be tempted, as CT is not the best modality for picking up small duodenal ulcers. So I would be tempted to do a scope, an endoscopy, a gastroscopy on this patient if I was satisfied that they were hemodynamically stable. In future, I think that would be my change of practice. In reality, he had no symptoms of that. There was no bleeding into the abdomen, into the lumen, the bowel. Either the stomach or the duodenum, but the bleeding instead was retroperitoneal, so there was blood in the paracolic gutter and then also spreading into the anterior abdomen as well. So that was in this case. But yeah, I think for future, consider gastroscopy would be very reasonable.
Yes, completely agree. And Professor Majid sir is here. He's got more experience in upper GI. It's been a very good surgeon. So have you ever come across this kind of cases in your life, Professor Majid?
Well, thank you very much for the asking me to make comments. But I felt tempted to ask the presenter with a patient who seems to have a retroperitoneal hematoma, as shown as has been mentioned. Did this patient complain of any back pain? Because a patient having a retroperitoneal hematoma, as shown in the CT, should have complained of pain in the back. I felt tempted to ask the presenter, did the patient ever complain of pain in the back?
Yes, excellent question, because you would have, with significant blood, it would really irritate the retroperitoneum. On admission, he had no pain in the back. He had no flank pain. He had no features of the pain going through to the back. And when we saw him on the ward round, I remember he did not have any radiation. I do not remember, I will admit, I do not remember that we asked him if he had any back pain ongoing after day 2, 3, 4. And I'd be interested, he would, whether he described some at least irritation, pain. Yeah, but definitely not in the first 24 hours.
The aortic aneurysm, when we see they come with the back pain, and especially retroperitoneal bleeding as well. I'm not sure whether this is a very rare condition. At the same time, the gastroduodenal artery was probably going through the bare area of the duodenum, but going directly to the retroperitoneal space and spreading out rather than causing any pressure effect and causing pain. But as we know that he did not mention that thing before. Okay, another question I can see from Shakib Kabir.
Yes, so the question is whether Gray Turner or Cullen sign developed later on. So apart from the epigastric fullness and slight tenderness, which was consistent throughout the week or so when he was admitted, there were no other abdominal findings. His abdomen was otherwise completely soft. There was no bruising anywhere, including on the flank or the back. Yeah, good question.
Yes, especially we occasionally see this kind of Gray Turner syndrome or also Cullen syndrome, but in particular this case, we haven't seen that. Good. I really like this question down in the chat box, and we're more than happy. It's an interactive program. So we really want to hear from you guys, especially the FRCA students, FCPA students there. Okay. Now, Professor Samia Mubin, what is your comment about his presentation? I'll be really glad to know from you, Samia.
Thank you. Dr. Shannon Bernard, you have done an excellent job, and the presentation was very, very nice. And the case was a super case. So it was really a brainstorming for everyone. I like the way you started the presentation of how a surgical case should be presented. And I want to specify to the point that you wanted the students to stick to the traditional method of presenting a case. And I should suggest this to my students as well, because I would advise my students to not to do experiments with your presentation. This is not a good idea, especially as long as you are trainees. So sticking to the traditional way is you don't miss anything when you stick to the traditional way of presenting a case like that Dr. Shannon did. And I am impressed with his performance of taking 40 patients a day. It's a great performance and great work. And after doing all these, you're presenting a case for us. This has been really impressive. Thank you for that.
Yes.
And the case.
Yeah, carry on, please. Yeah.
The case that you have presented is definitely a brainstorming for us, because at the beginning, from the the patient presented with upper abdominal pain, it seemed like it may be an easy case of cholecystitis or gastritis, or maybe a pancreatitis case, especially when the patient also had hypercalcemia and everything. So, and going to his history of thyroid surgery, his hypercalcemia, hypertension, I stick to the diagnosis is meant to be, and meant to, or maybe A or B.
Absolutely.
But you finally revealed the secret that it was not a medullary carcinoma at all. So there was the twist. So I like the thing that how you presented, and I would like to request the students here. You are all following the cases, and it is very interesting case. So why don't you participate? It's nothing to be feared of. Professor Modi sir is not going to mark you for your performance. I'd like my students to talk more about the case. Thank you.
Yep, great. We've got 75 attendees today. This is really great. I'm really, really happy. Now, students, I've seen another question here. Nazia Mahzabin. In rupture gastroduodenal artery aneurysm, any hematemesis or melena? If not, then why? We explained a few minutes ago. Okay, Shannon, you can repeat this one again.
Yes. So yes, exactly. So you may expect that if the artery, if the bleed was due to an ulcer, which it commonly is, then absolutely you may expect to have melena or hematemesis, because there would be blood going into the lumen of the small bowel. However, in this case, that was not the cause, and that it was it was more likely to be a spontaneous rupture of an existing defect due to the high blood pressure, in which case there was no communication with the bowel, and it instead leaked into the retroperitoneal space instead of the actual lumen. So you wouldn't get blood from either end of the GI tract.
Good answer. I hope you've got your answer. Now, please, again, if you're still feeling shy, or if still shy, you can write down in the chat box any question. Now, I'll go to Professor Khondekar A.K. Azad Bhai. I would like to ask you about this particular case, and whether the summary or the presentation style, do you like that style or not, from Shannon? Professor Azad.
Okay. Thank you, Dr. Zakirullah, and thanks everybody. Very nice to see you all. Thanks, Dr. Shannon Barnard, for your nice presentation. Very elaborate presentations. I think, as Zakirullah requested me to comment on this presentation, so I'll strict on this point only. So, as so many postgraduate students are here, I think I make one comment. I think Zakirullah was concerned about the initial clinical diagnosis based on this presenting symptoms of the patient. Probably there will be a low index of suspicions of this condition. So more frequent likely diagnosis, as Shannon Barnard told us about this cholecystitis, pancreatitis, and gastritis. So these parts of the etiology, that's a very low index of suspicions. Next thing is I have noticed one thing. Whenever a surgical resident presents the case, he tries always to focus on the surgical condition only. But we encourage the students to see or to focus his eyes in a broader aspect, like his or her medical conditions, his or her physical and performance status, physical status, nutritional status. So these are the things I think a resident should mention during presenting a surgical case. Ultimately, these three things: the patient nutritional status, patient's performing status, patient's physical status, and patient's anesthetic fitness, from your history. So I think that will reflect the risk of surgery and how a patient will behave. If the patient needs a surgery, how the patient will behave postoperatively, and we can predict and we can see the probable postoperative case of this particular patient. I think this part should also be included in presenting a surgical case of the patient. Like for our trainings as well, I think from our country FCPS MS students are here, so you should mention at least a nutritional status, at least a clinically a meds, and at least a clinically patient ECOG status. This is very, very important to predict the outcome and to assess the risk of surgery. Thank you, Dr. Shannon Bernard, again for your presentations, and thanks, Jacarullah.
Thank you very much, Azad Bhai. Thank you for your participation here. Definitely, all the time you're encouraging your junior doctors, especially the trainees. So now we can actually come out from this screen, particularly this displaying of screen, and we can talk directly now. So you can see each other. Please feel free. My main intention for organizing this kind of webinar is just so that we can learn from each other. Please, if you're brave enough to open your cameras and switch on your cameras, that would be great, that we can discuss. Honestly speaking, especially for the students, I really want that our students should be communicating with us, with the consultants. The traditional way of teaching has gone now. We are learning from each other, and especially with this internet era, especially we can Google anything, find out whether your knowledge might be much sharper, much better and updated than our consultant colleagues as well. So we have to learn, and we have to learn from each other. That's the main intention of this kind of webinar. Of course, it does not mean that we are not going to respect our consultants. We'll definitely respect our professor. They've got much better experience and better, of course, experience from learning and from seeing people as well. But we should exchange our knowledge. Now, can anybody from the students, anybody volunteer from PG or Dhaka Medical or Chittagong Medical, can comment about this particular presentation? What have you learned from this one? Anybody? Not particularly this case, I'm talking about the presentation. Anyone, please volunteer. Please don't be afraid.
Feel free.
Yeah, we can talk. You can switch off your camera. If you can talk, I'll be happy. Don't worry. Do you know why I'm doing it? Again, pushing everybody, because I want you to talk. And that is the only one thing is missing from our students. They're very knowledgeable.
Sir. Hello.
Walaikum Assalam. Nazia, very good. Tell me, how did you find?
So this is a very informative webinar, I must say that. And to Dr. Shannon, thank you for your elaboration and focusing. This is very the rare case, and I have some few questions for you. Can I?
Good. Can you please
say?
Go ahead, Razia, please.
Hello.
Yes, please.
Yeah. Okay. As finally the patient was treated by embolization by interventional radiologist, right? So what about the retroperitoneal blood that already present in the retroperitoneum? How you had treated that?
That's a very good question. I'm not sure. Shannon, you can answer, and I'm going to help you if you can to carry on.
Yeah, thank you, Mr. Ullah. Yes. So we so there was no surgical management of the retroperitoneal bleed, and this blood will be gradually resorbed, but there will be some probably residual sort of long-term granulation change in the retroperitoneum. But I would like, yes, my surgical consultant colleagues, is there a size of retroperitoneal bleed that you would consider not just leaving and that you would actually you would decide to drain either surgically or by interventional radiology?
That's a very good question, actually. I'm really impressed, Nazia, that you asked this question. 99.99% of the cases, retroperitoneal bleeding doesn't need to be touched. If you can stop the source of the bleeding, that will get absorbed by the body, and that's the only one thing you can do. And quite often, if you go to the retroperitoneal space, you'll not find any localized area of hematoma. It goes into the muscles, it goes into the fascial area and other areas as well. And at the same time, if you don't stop the bleeding source, it will continue to bleed. So it's better, and hematoma has a tamponade effect. So if somebody has got a bleeding in the retroperitoneal space, that normally has got tamponade effect that will stop the bleeding as well. So yes, most of the cases, we never have to go to the retroperitoneal space to clear. What about Professor Shahadat Hussain? Have you ever been to retroperitoneal space to evacuate the clot?
No, I absolutely agree. I absolutely agree with you. Probably this will automatically resolve. Unless there is huge hematoma that might cause sometimes the patient. In that case, we can consider this evacuation.
A bit listening around all the time. The only thing I want our students to start asking questions so that you will open up, and internationally you'll be much more successful when you talk. That's very important. We have got knowledge, but we have to talk and explain express your knowledge to others. That's what I want from this webinar. Another one or two questions and we'll finish. Definitely there's some chat box. There's a question here I can see, and that is from Sarwar to everyone. Which point from CT has made us suspicious regarding doing a vascular imaging if we have got such case in Bangladesh, as facilities are not available in all centers here? Number two, most of the cases, CT or MRI is the highest modality in our country. If we get such case preoperatively during exploratory laparotomy, how do you proceed to them? Very good questions. Right, Shannon, you can try. Although he's my five, he's the most junior doctors, but he's very knowledgeable. So I'm asking him to answer first. Yeah.
So the reason for the vascular imaging or the further vascular, the angiogram, so with more contrast, was because the pathology that we found in the abdomen was this all that such as myself could tell was that we had this hyperdense mass in the upper abdomen, and it was not clear whether it was, and we had the clinical picture of blood loss, and it was really unclear whether we had a situation where there was actually that mass could have been a tumor, and that we'd had some bleeding into a tumor, or whether it was actually just blood and that there was some type of inherent vascular issue which had caused the bleeding. So the reason for the further angiography was because we, just based upon the initial image, all we were going on was this hyperdense mass, which actually could have been blood or could have been, I mean, it wasn't very heterogeneous, so less likely to be a tumor, but it could have been. And you know, it's difficult to comment how we, depending on what facility you're working in, you know, what the best modality would be. I would ask Mr. Ola to maybe, if you don't have access to more sophisticated vascular imaging.
Right. That's a good question. First of all, particularly this CT scan did have some contrast study. I mean, it's not a vascular study, but it's just a contrast we always put. And take the pictures at arterial phase as well as in the venous phase. So in the arterial phase, you have actually seen some splashing. Something is coming out from the arteries and going to the surrounding tissues. That was indicative of some sort of either vascular injury or maybe ulceration or something is going on. When we do like large bowel bleeding, PR bleeding, massive bleeding is going on. I'm pretty sure Professor Shahadat has used that several times. When you don't know, you can't locate the area. Sometimes we use some mesenteric artery angiogram, or sometimes specific angiogram has been done, or even just a normal CT angiogram that will show some sort of bleeding spot, then you can go and identify that area and operate. If it is on the right side of the colon, you can do right colectomy. So these kind of things we can understand. Particularly this case, as you mentioned, when you saw that some sort of dye is coming out from this area, then the question will come, it is not coming, it is not going to the duodenum, it's not going to the stomach, there's no bleeding going on at all. It must be somewhere in the vessel causing the problem. So that's why we did this vascular, specific vascular and arterial scan or venous scan. Particularly the MRI. MRI is very good for soft tissue density or soft tissue structures to see. But our main objective here, I'm not expecting that in Bangladesh it will be easier. Main objective was to, whether interventionally we can stop that bleeding by putting a coil to stop that bleeding aneurysm. That's what has been done for a young chap without any laparotomy. In Bangladesh, of course, if you see this kind of bleeding going on, maybe only option would be a laparotomy. If you find a mass and some pseudogastroduodenal artery is bleeding, then probably gastroduodenal artery ligations would be or maybe some partial gastrectomy would be the right option for this guy. What do you think,
yes,
Professor?
Thank you very much. I was really, I felt tempted to intervene with relation to the question that was raised by one of the students from Bangladesh. Well, thing is this, insofar the assessment of this particular patient,
Sir,
can you hear me?
No, but now we can hear you again. Try again, sir.
Yes, this in the context of our country, where the vascular investigation is not that easily available. It is available, but it's not available universally in all institutions. But in this particular case, and retroperitoneum was not at all significant. If it was significant, the patient would have complained of pain in the back.
Yeah.
And that is a very common knowledge. In case of aortic aneurysm, in good old days, even in the UK, we used to make this diagnosis on clinical ground. I'm talking about mid-70s. Aortic aneurysm, we did not have any interventional radiology. It used to be, in the UK, I'm talking about UK, in mid-70s.
Yes, agree.
We used to go by parameters.
Yes, absolutely,
So,
absolutely.
in the context of our country, with this type of presentation, I'd go clinically, because even CT scan that's been done, it has not quantified that there was a huge amount of blood. And if there was any significant amount of retroperitoneal bleed, the patient would have definite, but it was not significant. And one of the students asked, what you do about the retroperitoneal blood? You do nothing, in fact, in a patient who does not complain of any pain back. That means there was no significant blood loss in the retroperitoneum. Can you hear me?
Yes,
Are you
yes,
hearing me? Or...
Absolutely.
Yes.
Absolutely, sir. Absolutely.
So in the context of our country, we are going to have this investigation that you have had recourse to, because this is very easily available in the UK, but we very sparingly use this investigation when it is absolutely indicated. So the students who raise this issue, what we do about this particular patient retroperitoneal bleed, you just leave it alone unless the patient has some symptoms. So masterly inactivity for a radiological, like CT scan evidence of retroperitoneal hematoma which does not produce any symptom, mostly inactivity and wait and watch will be the thing. This patient does not need any intervention, surgical intervention. That is the point I wanted to make. The other thing, but probably for medical legal reason, you have recourse to these various investigations, which probably would have been or could have been avoided also. This is my just a simple opinion. So thank you very much. This is all that I wanted to tell about this, but this was, I must say, Dr. Shannon, your presentation was very wonderful and all of us have enjoyed it. Thank you very much.
Thank you, Professor Majid, sir. Thank you very much for your encouraging words. Definitely Shannon will like that comment. Now, I've got a couple of questions. Gastroduodenal artery aneurysm cause. It's like any other causes of aneurysm. As we know, the high blood pressure is one of the factors, and also sedentary lifestyles, the atheroma formations and other conditions like an aortic aneurysm causes. Exactly, but pseudoaneurysm can happen with either the traumatic or it can happen with the high blood pressure related trauma cases as well. So the same kind of aneurysm, sometimes we don't know, unknown etiology, sometimes with erythromenologists, sometimes with the some sort of rheumatoid problems, some autoimmune disease process can cause this kind of thing as well. Now, complications of gastroduodenal artery embolism, it's like any other embolizations. It depends on where you're actually doing the embolization. If you do mesenteric artery embolization specific, we do go for very terminal branches. So normally it will be just local ischemia can happen. Sometimes if it is actually blocking the whole artery, then you can get some ischemic bowel and infarcted bowel as well. In this particular case, gastroduodenal artery, we sometimes tie and ligate. When you've got a profuse bleeding going on, you cannot actually control it from a gastroduodenal. If you made a gastrotomy and then try to stop the bleeding, you cannot do it. You have to find out. You have to find out the gastroduodenal artery and tie it off. Normally, there is no real major complications happen, but of course, a gastroduodenal artery embolization is done very, very, very rarely. So other complications can happen, like traumatic injury to the vessels and nearby vessels as well. Now, can I ask Professor Azad, sir, I'd be grateful if you can actually tell me whether students have learned anything from this particular presentation. Yes. I'll ask students as well.
Okay, thank you. This is one of a new experience for them, how students from who passed from a Cambridge University is presenting a case, a surgical case particularly. And I think Professor Samia Mubin has explained something about the presentation of the case. And student, I think this should be done because of this exchange of these ideas and exchange of this presentation, mode of presentation. So I think they will learn, we will learn. So this is the way of the learning process. And I think another part of the important of Dr. Shannon's presentation was involving a multidisciplinary team in his management team approach plan. So that is also one of the way from very beginning. He emphasizes these multidisciplinary team management. That is also an important side of his presentation. Very good.
Thank you
for your presentation.
Thank you very much. Right? Yeah.
One thing to our students, just open your mouth, speak out, tell something, do mistake here, and learn from here. That's an important thing.
Brilliant.
Mr. Ola, I apologize. I think I'm going to have to leave. There's a chest drain in emergency department.
No problem. Before you go, just to thank you. Yeah, of course, leaving very soon as well. Thank you very much, Shannon, for your fantastic presentation. I'm sure everybody enjoyed your presentation. At the same time, it's a very rare case, although not a day-to-day work, we see this kind of cases, but it is definitely an interesting case. And you explained how to describe, how to actually plan your presentation. And I'm really grateful. And thank you from all of us.
Thank you all
Shannon.
for coming. Okay, take care.
Thank you. Go and put a chest drain. Let me know what's happening. Thank you. Now, চলে যাওয়ার আগে আমি বলছি সবাইকে কাইন্ডলি নাজিয়া, আমি তোমার মধ্যে লাস্ট কোয়েশ্চেন ছিল। থ্যাংক ইউ শানন, ভেরি গুড। নাও সবাই কি একবার হাত তুলে বলবা কারো উপকার হয়েছে কিনা? আমি ইচ্ছে করে বাংলায় বললাম, কারণ আমি সত্যি চাই নেক্সট টাইমে one of you is going to present this case. One of you have to present this case, not this particular case, this kind of cases, and I'll get some British doctors as well as British professors to come and join with us so that we can learn from them, as we can learn from you guys, and they can actually appreciate your presentation. That will be my achievement. Yes, bhai bolun Kazat bhai.
Yes, আমি যেটা বলতে চাই, যে পেশেন্টটা আজ প্রেজেন্ট করা হলো শারন, তার ক্রনোলজিক্যালি আমরা যদি দেখি, অ্যাকচুয়ালি দিস ইজ ওয়ান অফ দ্য রেয়ার কেস। এই ধরনের কেসগুলোকেই আমরা অ্যাজ এন আইডিয়াল কেস হিসেবে চিন্তা করব না।
No, of course not. Of course not.
চিন্তা করব কোনো একটা সার্জিক্যাল কেস, সার্জিক্যাল কেসের প্রেজেন্টেশনটা কি হতে হবে, ওর মধ্যে কি কোর ইনফরমেশন গুলো থাকবে, এবং এই কোর ইনফরমেশন যেগুলো আমি প্রোভাইড করব, সেই কোর ইনফরমেশন যেগুলো যখন প্রোভাইড করছি, তখন থেকেই যেন আমার প্রেজেন্টেশনটা যিনি শুনছেন উনি বুঝতে পারেন যে আমি আমার প্ল্যানটা কি, আমি কতটুকু অ্যাসেস করেছি, কতটুকু মানে ডায়াগনস্টিকের কাছাকাছি যেতে পেরেছি, ফিউচার ইনভেস্টিগেশন আমার প্ল্যানটা কি হবে, এই এবং সেই ডিজিজ রিলেটেড কোনো কমপ্লিকেশন বের করার আমি কোনো চেষ্টা করেছি কিনা, আমার প্ল্যানটা কি সার্জিক্যাল কোনো ইন্টারভেনশন কিনা, পেশেন্টের কনকারেন্ট মেডিকেল ইলনেস গুলা কি, কতটুকু কন্ট্রোল আছে, এই কন্ট্রোল না থাকলে সেটা আমার সার্জিক্যাল ম্যানেজমেন্টের জন্য কতটুকু মানে ইম্প্যাক্ট করবে বা হ্যাম্পার করবে, এই পেশেন্টটার জন্য এই সমস্ত অ্যাসেসমেন্ট গুলো কিন্তু আমার এই সার্জিক্যাল হিস্ট্রি এবং প্রেজেন্টেশনের মধ্যেই চলে আসতে হবে, ইনক্লুডিং দ্য অ্যানাস্থেটিক ওয়ান। কারণ একটা পেশেন্টকে আমার টেবিলের সামনে আছে, আবার কিন্তু সেকেন্ড টাইম আমি বলতে পারবো না যে আপনি আবার আসেন, আবার কিছু আপনার থেকে হিস্ট্রি নিব, আবার কিছু শুনবো, আবার কিছু অ্যাসেস করবো। সো দিস ইজ এ ওয়ান টাইম যখনই পেশেন্ট আসবে। তো এই জন্য টোটাল হিস্ট্রি ইন এ টোটালিটি প্রেজেন্টেশনটা আমাদের মধ্যে রাখতে হবে। এবং আমি একটা ল্যাকিংস ডক্টর জাকিরুল আমি দেখতে পাই সব মানে স্টুডেন্টের ক্ষেত্রে, যে এই জায়গাটা মানে খুব কম অ্যাড্রেস করা হয়। একটা হচ্ছে নিউট্রিশনাল সাইড অফ দ্য পেশেন্ট, একটা হচ্ছে পেশেন্টের ফিজিক্যাল স্ট্যাটাস, একটা হচ্ছে পেশেন্টের পারফরমেন্স স্ট্যাটাস, and about the patient's anesthetic fitness from the history. যেমন সে আমি যদি এখানে আমি একটু ক্রিটিক্যালি করতে চাচ্ছি যে এই পেশেন্টের ক্ষেত্রে পেশেন্ট হ্যাড থাইরয়েড অ্যানাস্থেসিয়া, বাট whether the patient had any bad experiences during that anesthesia, that's a very important history that I want to know. কারণ that history আমাকে গাইড করছে whether I need to take some extra precautions this time or not. সো আমার কথা হচ্ছে যে আমি ডায়াগনোসিসে এতদূর পর্যন্ত এইভাবে যেতে হবে, একটার পর একটা স্টেপ বাই স্টেপ আমরা যাচ্ছি, বাট আবার ইনফরমেশন গ্যাদারিং দ্য ইনফরমেশন ইজ ভেরি ইম্পর্টেন্ট ফর এ কম্প্রিহেন্সিভ ম্যানেজমেন্ট অফ দ্য পেশেন্ট। ওকে, দিস মাচ।
কমপ্লিটলি এগ্রি আজাদ ভাই, আমি একদম একমত আপনার সাথে, সবার সাথে। তো আমরা শেষ করার আগে আমি খালি দেখলাম মাত্র 3 জনের উপকার হয়েছে এইটা শোনার পর, দেখছি 3টা হাত উঠেছে, আর কারো বোধহয় উপকার হয়নি। কোনো অসুবিধা নাই, আমি পার্টিকুলার কেসের কথা বলছি না, বাট আমার আমি উপকার যদি কারো এখনো পছন্দ হয়ে থাকে এখন হাত তুলতে পারে, আর যদি না, ভেরি গুড। কারণ আমি বারবার যেটা বলছি, আমার বাংলাদেশকে নিয়ে প্রচন্ড গর্ব করি। আমি সবসময় বলি, সামিয়াও জানেন, স্যারও সবাই জানেন, এবং আমি এখানে কাজ করছি ঠিকই, কিন্তু সবসময় বাংলাদেশে যদি কিছু একটা করা যেতে পারে, বাংলাদেশে অসম্ভব ভালো ভালো টিচার আছেন, অসম্ভব ভালো ভালো প্রফেসর আছেন, আমাদের ছেলেপেলেরা অসম্ভব নলেজেবল। খালি একটা কথা বলতে অভ্যাস করতে হবে, তাহলে দেখবে একবার যদি বলা আরম্ভ করো, প্রেজেন্টেশন করতে আরম্ভ করো, দেখবে যে তখন অনেক ইজি হয়ে যায় প্রেজেন্টেশন করাটা, এবং তখন তোমার লেখা মানে লিখতে, পড়তে, বলতে এবং কথা বলতে কনসালটেন্টের সাথে এবং পরীক্ষা পাস করতে অনেক সোজা হয়ে যায়, তাই না সামিয়া? তোমার কি মনে হচ্ছে, তাই না? যদি কমিউনিকেট করি বেশি।
যেটা হয় যেটা আমাদের বিএসএমএমইউ তেও আছে, আমি শিওর অন্যান্য ঢাকা মেডিকেলও আছে, সব টিচিং হসপিটাল গুলাই কিন্তু সকালে একটা মর্নিং সেশন হয়, এবং সেই মর্নিং সেশনে রেগুলারই কেস প্রেজেন্ট করা হয়, এবং সেখানে এক্সামিনাররা থাকেন, টিচাররা থাকেন, ফেলো স্টুডেন্টসরাও থাকেন, যে তারা প্রশ্ন উত্তর করে, ডিসকাশন করে। কিন্তু ওখানে আমি দেখেছি যে আমাদের পার্টিসিপেশন ফ্রম দ্য স্টুডেন্ট সাইড সবসময় একটু কম থাকে, কারণ ইটস লাইক ওখানে টিচাররা বসে আছেন, এক্সামিনাররা বসে আছেন, তারা প্রশ্ন করছেন, যিনি প্রেজেন্ট করছেন উনি উত্তর দিচ্ছেন, তাতে দেখা যায় যে ফেলো স্টুডেন্টরা অত হয়তো এগিয়ে আসে না। কিন্তু আমার মনে হয় এই প্ল্যাটফর্মে হয়তো স্টুডেন্টসরা আলোচনাটা বেশি করার একটা সুযোগ ছিল, বা করবেও হয়তো ভবিষ্যতে যদি আপনি এটা আরো কন্টিনিউ করেন। তাহলে এটা তো প্রথম দিন ছিল, সো প্রথম দিন বুঝতেও তো সময় লাগে হোয়াট ইজ গোয়িং অন। এই
না,
জন্য
I
আমার
agree.
মনে হয় পরবর্তীতে আলোচনাটা হয়তো আরো সহজে উঠে আসবে। আর এটাই
আমি
আর
সেটা আশা
আর
করি।
যত বেশি, এটা ঠিকই যে যত বেশি আলোচনার সুযোগ হবে, যত বেশি আলোচনা করা হবে, তত কিন্তু পরীক্ষার জন্য ইজি হয়। এই যে আমরা যেরকম আমাদের কোর্সের স্টুডেন্টদেরকে আমরা সবসময় চেষ্টা করি পরীক্ষার আগে যেন ওরা বেশি করে প্রেজেন্ট করে, সো দ্যাট ওদের যে জড়তাটা আছে পরীক্ষায় ফেস করে লং কেস বলার সময় বা ভাইবা ফেস করার সময়, এগুলো যেন না থাকে আর কি, কেটে ওঠে।
Absolutely, Samia, absolutely. শাহাদাত ভাই, আপনারও সেরকম এক্সপেরিয়েন্স, তাই না?
Yeah,
প্রফেসর হাই স্যার জয়েন করেছেন। ওয়েলকাম স্যার।
ওয়ালাইকুম আসসালাম রহমতুল্লাহ।
আমি খুব খুশি হয়েছি আপনি জয়েন
ভালো
করেছেন।
লাগলো।
সরি আমি আপনাকে সরাসরি পাঠাতে পারিনি, কিন্তু আপনি এখান থেকে শুনে এসেছেন, খুবই খুশি হয়েছে স্যার। বলুন স্যার।
খুব ভালো লাগলো, খুব ভালো ডিসকাশন হয়েছে। আর পুরোটা দেখতে পারিনি, কিছু কিছু দেখে যাই মাঝে মাঝে, আমার কয়েকটা ডিস্টার্ব হয়েছে আর কি। যাই হোক, ভালো লাগলো। এরকম আমরা যে শুরু করছি, সেক্ষেত্রে যেটা শুরু করছি, এটা খুব ভালো লাগছে আমার কাছে।
আপনি তো আরম্ভ করেছিলেন অনকোলজির সমস্ত কিছু। আমরা এই যে অনকোলজির সাথে কত সুন্দরভাবে কথা বলছে আজকাল, আমরা সেটা সার্জারিতে আরো বেশি করে আনতে চাই।
ইনশাল্লাহ, ইনশাল্লাহ আসবে। খুব ভালো উদ্যোগ হয়েছে, ইনশাল্লাহ আসবে।
অনেক ধন্যবাদ স্যার।
আসবেন দেখে পারছে।
দেখি ইনশাআল্লাহ, দেখা যাক ইনশাআল্লাহ। আমি অনলাইনে আসবো ডেফিনেটলি। আমাকে আজাদ ভাই বলেছেন অনলাইনে ডেফিনেটলি আসবো ইনশাআল্লাহ। ভাই, আপনাকে যেটা আমাদের স্টুডেন্টদের মধ্যে যে জিনিসটা আমি একটু দেখেছি, তারা কিন্তু আবারও বলছে, তার প্রচন্ড নলেজ, কিন্তু বলার সময় কেন ভয় পাচ্ছে? আমরা কি টিচার ভয় দেখায় ওদেরকে?
না, এই কেসটা হয়তো তুমি দেখতে পেলে, এই কেসটা একটু আনকমন কেস, তো এই জন্য তারা
কথাই বলছি না, ইন জেনারেল।
ধরো অ্যাজ এ হোল যদি তোমার যে কিছু কেস প্রেজেন্টেশন ওরা ছিল, সেখানে কিন্তু আরো বেশি পার্টিসিপেশন ছিল, কারণ নর্মালি যে কেসগুলো সাধারণত ডিল করে, ধরো এই এখন যদি প্রেজেন্ট হইতো একটা সিএ ব্রেস্ট, সিএ রেকটাম, সিএ রাইট কোলন, এই কেস প্রেজেন্টেশন হলে হয়তো পার্টিসিপেশনটা আরো ইজিয়ার হইতো, কারণ কেসটা ভেরি আনকমন। তো এই জন্য একটু ওপেন আপ হইতে আমার মনে হয় যে, যেমন আজাদ স্যারের যে ক্লাসগুলো হয়, সেখানে তো স্টুডেন্টরা অনেক পার্টিসিপেট করে, বিকজ যে পরীক্ষার সময় যে কেসগুলো হয়। তবে আমার প্রেজেন্টেশন সম্পর্কে আমার একটা ওপিনিয়ন আছে, সেটা হচ্ছে যে আমরা যেভাবেই করি না কেন, স্টুডেন্ট কিন্তু আমরাও কারো ভালো প্রেজেন্টেশনটাকে কপি করতাম, যে এই প্রেজেন্টেশনের স্টাইলটা ভালো, এটা কপি, এটা দোষের কিছু না। স্টিল দেন 100% স্টাইলটা চেঞ্জ হয় না, একটা স্টুডেন্ট তার ওন স্টাইলই প্রেজেন্ট করে। বাট আমরা টিচার বা যারা এক্সামিনার, আমার মনে হয় আমরা ওটাতে অনেক স্যাটিসফাইড হওয়া উচিত, যদি স্টুডেন্ট ওন স্টাইলে করেও একটা আন্ডারস্ট্যান্ডেবল পিকচার দাঁড় করাতে পারে, এন্ড নলেজ থাকলে পরবর্তী অ্যাপ্রোচ গুলো যেন কারেক্ট ওয়েটা হয়। চাকরি হলো, তোমার কি মতামত?
একদম তাই, একদম তাই শাহাদ ভাই। কারণ আমরা তো কেউ চাই না একজনকে কপি করুক। উই ডোন্ট ওয়ান্ট দ্যাট। জাস্ট একজন থেকে আমরা লার্ন করবো, বুঝবো যে কিভাবে ওরা প্রেজেন্ট করছে। যে আমি বলবো যে আমি শ্যাননের প্রেজেন্টেশন আগে দেখেছি, আজকে তো অত ব্রিলিয়েন্ট ছিল না, হয়েছে ভালো হয়েছে, কিন্তু আপনার আরো ব্রিলিয়েন্ট বলে, যেমন ফ্ললেস যেগুলি বলা হয়, তার জন্য অনেক প্র্যাকটিস করতে হয়। তবে অ্যাজ এ জুনিয়র মেম্বার অফ দ্য টিম যতটুকু সে করেছে, আই এম রিয়েলি ইমপ্রেসড যে সে অ্যাটলিস্ট কাজ করেছে, চিন্তা করেছে যাতে কি কি আসতে পারে, কি কি ডিফারেন্সিয়াল ডায়াগনোসিস হতে পারে, কিভাবে এটার সাথে এক্স্যাক্টলি সেই জিনিসগুলি শেখানো। সেই জন্য আমি বললাম সেটা দেখানো। তারপরে স্টাইলটা নিজের, কারণ আমি কিভাবে কথা বলবো, কিভাবে আমি ইমপ্রেস করবো আমার কনসালটেন্টকে।
আমি সারা জীবন চেষ্টা করলে তো জাকিরুল্লাহর মতো স্টাইল আনতে পারবো না, তাই না? এটা ওন স্টাইল থাকবে।
আপনি সাধারণত আপনার অন্য স্টাইল আছে, একটা ডিফারেন্ট স্টাইল। 25 স্টাইল ইজ ডিফারেন্ট, তাই না?
জাকিরুল্লাহ চাইতে ভালো হতে পারে।
হ্যাঁ, অবশ্যই ভালো, আমি সেটাই বলছি, অনেক ভালো। আমি খুব খুশি হলাম, স্টুডেন্টরা অনেকে জয়েন করেছে। থ্যাংক ইউ ভেরি মাচ। ইটস প্রবাবলি 10 past 11 নাও, তোমাদের অনেক দেরি হয়ে গেছে। Any comment from anybody before I conclude?
বাট একটা রিকোয়েস্ট, সেটা হচ্ছে যে এরকম যদি কারণ তোমার আমি কিছু প্রেজেন্টেশন আগে, আমি যেরকম কমন কেসেস এখানে কিন্তু আমাদের এখানে FRCS পরীক্ষা দেয়, MRCS পরীক্ষা দেয়, এরকম স্টুডেন্টও কানেক্টেড এখানে আছে। হ্যাঁ, সো মানে একটা কেস না, ধরো কয়েকটা কেস ডিল করে, কিছু কি পয়েন্ট যেই জায়গাগুলো এরকম করে তুমি নিজেও একটা ক্লাস নিতে পারো। স্টুডেন্ট ক্যান বি কানেক্টেড।
অবশ্যই আমি করব, এবং এটা এই PH এর মাধ্যমে যদি আসতে পারি বা অন্যান্য ভাবে আমরা আসতে পারি, যেভাবে সামি আমাদেরকে আগে ডাকতো, তারপরে স্যার তো হাই স্যারের প্ল্যাটফর্ম তো আছেই, তারপরে আমি আজাদ ভাই এখন আবার ইনক্লুড করছেন। আমি চেষ্টা করব যতজনকে আনতে পারি আমরা, কারণ এখন ওয়াইডার পৃথিবী এত কাছে হয়ে গেছে এবং আমাদের এরা এত বিউটিফুল ভাবে কাজ করছে, ছেলেপেলেরা স্টুডেন্টরা যখন লেখে আমাকে উত্তর দেয়, আমার কাছে খুব অবাক লাগে যে এত নলেজেবল ওরা, মাশাআল্লাহ। খালি একটা জিনিস বিফোর আমি চলে যাওয়ার আগে বলি, রিসেন্টলি শুনলাম আমাদের নাকি কনসেন্ট নেওয়া হয় যারা পয়সা নেয় আমাদের প্রাইভেট হসপিটালের কথা আমি বলছি, যখন কনসেন্ট দেওয়া হয় তখন দেখি সার্জনরা বা ডাক্তাররা কনসেন্ট নেন না, ওই ক্লার্ক কনসেন্ট বলে এখানে সিগনেচার বানেন, এখানে সাইন বানেন। এটা কি সত্যি কথা? যে পয়সা যখন দিতে যাবে তখন বলে যে এখানে কনসেন্ট দেন, এটাই কি আসলে চলছে এখন বাংলাদেশে?
ইটস নট জেনারেলাইজড।
ওকে, কিন্তু কনসেন্ট নিয়ে আমি একটা করবো। আমাদের দেশ এখন বেশি দূরে নাই, কয়েকদিন পরে কিন্তু আমি বলছি সু হওয়া আরম্ভ হবে। এতদিন পর্যন্ত আমাদের সু হয়নি, কিন্তু আমি প্রিটি শিওর 5 থেকে 10 বছরের মধ্যে কোনো একজন ডাক্তার বা আমরাই কেউ একজন ধরা খেয়ে যাব যে আমরা ঠিক মতো কনসেন্ট নেই নাই, পেশেন্টকে ঠিক মতো বুঝাইনি, যেটা এখানে হচ্ছে। 90% এর কেসেস যতগুলি কমপ্লেন হচ্ছে না এখানে এবং আমেরিকাতেও, 90% কিন্তু কমিউনিকেশন গ্যাপের জন্য হচ্ছে। ডাক্তার বলে নাই রুগীকে, রুগী হয়তো বুঝে নাই এবং তারপরে সু করে দিয়েছে, পুরো চাকরি চলে গেল। আমেরিকাতে একবার চাকরি গেলে আর ইন্স্যুরেন্স কোম্পানি চাকরি দিতে মানে আপনাকে করবেই না, এরপর চাকরি পাওয়া ডিফিকাল্ট। ইংল্যান্ডেও তাই হয়েছে। তবু আমরা এই জন্য আমার মনে হয় বাংলাদেশের কমিউনিকেশন স্কিলটাকে একটু বাড়াতে হবে আমার মনে হয়। হ্যাঁ,
আমি একটু বলতে চাই যে বেটার টু ওয়ার্ক টুগেদার, দ্যাটস এ স্ট্রেংথ। আমার মনে হয় যে এই ধরনের ফার্দার আরো কিছু কেস যেটা সহজ বললেন করলে বেনিফিটেড। এন্ড ফাইনালি আমি একটু অপরচুনিটি দিতে যাচ্ছি প্রফেসর। হাই স্যার, আসসালামু আলাইকুম। ভালো আছেন স্যার?
আলহামদুলিল্লাহ, এই যে মিশনে জয়েন করছি।
নেক্সট 16 স্যার ইনশাআল্লাহ দেখাবো, যেটা ইনশাআল্লাহ নেক্সট 16। প্রফেসর মজিদ স্যার, আসসালামু আলাইকুম স্যার, ভালো আছেন?
ওয়ালাইকুম আসসালাম ওয়া রাহমাতুল্লাহি ওয়া বারাকাতুহু। হ্যাঁ, আলহামদুলিল্লাহ ভালো।
দেখা হবে স্যার ইনশাআল্লাহ আমাদের। ওকে,
সামি কি বলছিলে?
সাথে দেখা হবে ইনশাআল্লাহ। ওকে সামি, হ্যাঁ সরি
সামি
আনমিউট করো, সামি আনমিউট করো।
সরি, আমি এই যে কনসেন্টের ব্যাপার যেটা বলতে চাচ্ছিলাম, আমি আপনাদের ওখানে ফর্ম দেখেছি, এটা কি অপারেশন হবে, কি কি কমপ্লিকেশন এক্সপেক্টেড, এগুলো আসলে আমরা পেশেন্টের, যদি প্রাইভেটের কথা যেহেতু বলেছেন, আসলে মোস্ট অফ দ্য সার্জনস যারা করে ওরা পেশেন্টকে যখন একটা অপারেশনের জন্য কথা বলে তখন কিন্তু মূলত কি অপারেশন করবে, কেন করবে, কি কি কমপ্লিকেশন এক্সপেক্টেড, কি কি সাকসেস এক্সপেক্টেড বা কি রেজাল্ট হতে পারে, এগুলা কিন্তু চেম্বারেই ডিসকাস হয়ে যায়। দ্য থিং ইজ দ্যাট চেম্বারে কখনোই কনসেন্ট পেপার সাইন করা হয় না, কিন্তু ডিসকাশন ইজ দেয়ার। ডিসকাশন ছাড়া কখনো কোনো রোগী কনভিন্স হবে না যে আমার কাছে এসে অপারেশন করবে। সো অপারেশন করার আগে রোগীরা অনেক সময় মাল্টিপল টাইমস এসেও ডিসকাস করে, কিন্তু আপনাদের ওখানে যেটা হয় যে আমি দেখেছি বিফোর অপারেশন আপনারা নিজেরা যান, এভরিথিং আপনার যা যা ডিসকাস করছেন সেই পয়েন্টগুলাই লিখে রাখেন আর অনেক বড় কনসেন্ট পেপার। বাট আমাদের কনসেন্ট পেপারটা যে আমি আমার রোগীর শখে সম্পূর্ণভাবে অজ্ঞান করিয়া রোগীর স্বার্থে অপারেশন করিবার জন্য রাজি আছি, সব হাসপাতালে ফর্ম চলে এবং ব্যাপারটা ওইভাবেই হয়। বাট দ্য থিংস আর অলওয়েজ ডিসকাসড। এখন আপনি যেটা বলছেন যেহেতু এটা মেডিকো লিগাল ইস্যুস এখন বার্নিং, বাংলাদেশও এটা খুবই বার্নিং ইস্যুস এখন মেডিকো লিগ, বুঝুক না বুঝুক মেডিকো লিগাল ইস্যু তো থাকেই। তো সেই ক্ষেত্রে যেটা করতে পারি যে আপনাদের মতো ডিটেইল ফর্ম যেটা আমরা চেম্বারে ডিসকাস করি ওইগুলা ইন্ট্রোডিউস করা যেতে পারে। তো সেটা আসলে এটা আসলে পলিসি মেকারদের থেকে বা হসপিটাল থেকে ঠিক হতে হবে, বাট ইউ ক্যান অফ কোর্স অলওয়েজ ডিসকাস দ্য থিংস, শেয়ার করতে পারেন আপনাদের ওখানে কি হচ্ছে, যেটা আমরা আমাদের এখানে আমরা ভালোটা অবশ্যই নিতে পারি।
থ্যাংক ইউ সামিয়া। তার আগে বলি স্যার প্রফেসর মজিদ স্যার কিন্তু আমি কিছুদিন বলে আমার কাছ থেকে কনসেন্ট ফর্মগুলো আমি পাঠিয়ে দিয়েছি অলরেডি।
Thank
স্যার
you.
কিন্তু অ্যাক্টিভলি কাজ করছেন বিহাইন্ড দ্য সিন।
তবে হ্যাঁ, thank you, Zakir. I got those forms. Actually, ব্যাপার হচ্ছে কি, এই forms গুলা he has changed dramatically over the years in the UK also, because during our time, even up to 2004-5, it was not as detailed as it is now, and that is very good, in fact. And as Samina has mentioned, we discuss, especially I discuss everything, but I do not discuss, I discuss the complication of a specific surgery. For example, if you am doing a lap poly, I'm going to explain to him what I'm going to do and what are the attendant complications and what can be the other alternative procedures. Everything is discussed. But the question is, and I do it myself, but unfortunate reality is that all of us do not do it that way. They leave it to the juniors. That should not be done. That is the point I'll try to make. And in fact, I had recently discussed with the Director General of Health Services about formulating a consent form, which will be printed by the busy press, Bangladesh government press. I discussed it with him. And in fact, we are going to meet soon all the teachers of different institutions. That is what I have been thinking about before I collected this consent from you. And I have collected consent forms that are used in different institutions in our country. আমাদের দেশে ভিন্ন মেডিকেল কলেজ, বঙ্গবন্ধু মেডিকেল ইউনিভার্সিটি, সব কনসেন্ট ফর্ম কিন্তু আমার কাছে এখন অ্যাভেলেবল। তবে আমরা we are going to work out a consent form which will be very much morally right, morally and ethically right also. I cannot say like some of the consent form says যে রোগী যদি মরে যায় তবে এর জন্য হসপিটাল কর্তৃপক্ষ দায়ী না, এরকম কথাও লেখা থাকে, which is morally and ethically absolutely wrong. So we are going to formulate a consent form, and I have suggested to the appropriate authority that once we have worked it out, আমাদের গভর্নমেন্ট বিজি প্রেস থেকে এটা প্রিন্টেড হবে. It will be a government paper and it will be available in all government institutions and also in the private institutions. সেটা চিন্তা ভাবনা হচ্ছে, তবে we have to work on it. এতটুকুই আমি বলতে চাচ্ছি on this issue.
অনেক ধন্যবাদ স্যার। সো অনেক রাত হয়ে গেছে, অসংখ্য ধন্যবাদ যারা জয়েন করেছেন, এবং আমি আবার পার্টিকুলারলি আমার প্যানেলিস্টদেরকে বলছি থ্যাংক ইউ ভেরি মাচ, প্রফেসর মাজিদ, সামিয়া মুবিন, প্রফেসর আজাদ ভাই, and also ঝন্টু ভাই, and Professor Hi sir as well. Thank you.
আসসালামু আলাইকুম। আসসালামু আলাইকুম। একটু আমি প্রফেসর খুরশিদ বলছিলাম।
খুরশিদ ভাই, আসসালামু আলাইকুম।
ওয়ালাইকুম সালাম। সরি আমি সময়টা মিস করেছি, তারপরে শেষ মুহূর্তে মজিদ স্যারের একটু কথা শুনলাম, তো ভালো লাগলো।
আপনাকে খুব দরকার, আমাদের সবারই দরকার। আপনি যতদিন মানে ডিজি হেলথ যতদিন আছেন ততদিন যতগুলি ভালো কাজ করা যায়, কারণ আপনাকে আমি পার্সোনালি চিনি খুরশিদ ভাই, ভালো কাজ ছাড়া খারাপ কাজ কখনো দেখি নাই। আমরা চেষ্টা করবো যতটুকু পারা যায় আমাদের খুরশিদ ভাই আমাদের জিনিসটাকে ভালো করে।
ঠিক আছে, থ্যাংক ইউ। তারপরে শেষ পরে সবাইকে সালাম এবং শুভেচ্ছা। আজাদ ভাই আমাকে বলেছিল আগে যোগ দিতে, কিন্তু আমি পারিনি, বেরোতে দেরি হয়েছিল। এরপরে একটা সোশ্যাল প্রোগ্রাম ছিল, মজিদ স্যার এই প্রপোজালটা আগে আমাকে দিয়েছিল, তাই আমি ওয়ার্কিং অন ইট। আমরা একদিন ডিজি অফিসে ডাকবো, মানে আমাদের প্ল্যানিং থেকে যেখান থেকে এগুলো করা হয় আর কি। এরপরে আমরা হসপিটাল সার্ভিস ম্যানেজমেন্ট এবং হসপিটালকে ইনভলভ করবো, এইটুকুই বলতে পারি।
অনেক ধন্যবাদ খুরশিদ ভাই, অনেক ধন্যবাদ, থ্যাংক ইউ ভেরি মাচ। আপনি বছর পর বছর এই পোস্টে থাকেন, আরো আরো বড় পোস্টে যান, এটা চাও করি মেডিকেল সিস্টেমটা যেন ভালো হয়ে যায় ইনশাআল্লাহ। অনেক ধন্যবাদ সবাইকে। তো আজকে তাহলে এখানেই বিদায় নিচ্ছি।
ওকে,
খোদা হাফেজ।
আসসালামু আলাইকুম।
বাই বাই।
আসসালামু আলাইকুম।
ঠিক আছে।
ওয়ালাইকুম আসসালাম।